Hi there, welcome back to Boards and Beyond. I'm Dr. Heather Delaney, and welcome to our module on Pediatric Fluid Management. Fluid management in hospitalized children is critical to reducing morbidity and mortality. The vast majority of a child's weight is water, equal to 75% of an infant's weight and 60% of a child's weight in kilograms. Children are very sensitive to fluid status as they get dehydrated easily when illnesses arise, such as gastrointestinal illnesses due to the inability to drink adequate fluids or ongoing losses due to vomiting, respiratory compromise due to increased insensible water loss or metabolic demand from tachypnea, neurologic impairment where a child may not be safe to eat or drink by mouth, or in preparation for surgery requiring an NPO or nothing per mouth order, or during the post-operative state where a child has not established return of bowel function with the presence of bowel sounds. If the child is not able to take fluids by mouth for whatever reason, possibly if they are NPO in preparation for surgery or found to be dehydrated and unable to rehydrate with fluids by mouth, this patient should be given IV fluids. Intravenous fluids should be thought of as a medication, and it's important to order the correct volume and composition to ensure homeostasis is maintained. This preserves a child's extracellular volume as well as minimizes the risk of developing volume depletion, fluid overload, or electrolyte disturbances such as hyponatremia or hyperkalemia. Historically, nutritional requirements for IV fluids were extrapolated from the composition of human breast milk. This includes a form of sugar as a percentage of dextrose, where D5% equates to 5 grams of dextrose in 100 mL of fluid. Additionally, the average child generally requires 3 to 5 milliequivalents per 100 mL of sodium and 2 to 3 milliequivalents per 100 mL of potassium. We will talk more about these electrolyte requirements in the next couple of slides. Now, when a child is admitted to the hospital, allowing for enteral nutrition or allowing the patient to eat or drink by mouth is always preferred if feasible and safe to do so. However, if a child has limited or no nutritional intake, you'll want to add dextrose to their IV fluids. Again, the dextrose content of fluid is represented by a percentage of dextrose, meaning D5% equals 5 grams of dextrose in 100 mL of water, and would be abbreviated as D5W. The majority of children will require 5% dextrose in their maintenance IV fluid. One exception to this is neonates who will likely require 10% dextrose or more for nutritional requirements. Another exception to this are children with metabolic disorders who have very special and unique nutritional requirements. You will want to talk to a metabolic specialist when these situations arise. For patients receiving maintenance IV fluids for greater than 96 hours as a primary source of hydration or nutrition, you'll want to consider alternative sources of nutrition, including what's called parenteral nutrition or TPN, which includes fats, sugars, and proteins. When providing supplemental sodium, IV fluids are written as a fraction of normal saline, or NS. Full normal saline equates to 154 milliequivalents per liter, or 1,000 mLs, which is generally thought of as an isotonic fluid. Half normal saline, which is 77 milliequivalents per liter, and quarter normal saline, or 38.5 milliequivalents per liter, both are thought of as a hypotonic fluid. The reason why we distinguish between isotonic and hypotonic fluid in medicine is because solutes, or the stuff that we put in IV fluids, have a huge impact in cell homeostasis, with sodium being the largest driving force of fluid osmolality and tonicity. Osmolality is the measure of permeable and non-permeable solutes and is defined by this following equation. The take-home point here is to have an idea of what kind of solutes drive osmolality, again, mainly sodium. Tonicity is defined as the net force across a cell membrane based on osmotic pressures where an isotonic solution will not drive fluid across the cell membrane, maintaining intra- and extracellular homeostasis, whereas hypotonic solutions will drive water into a cell and hypertonic solutions will drive fluid outside of a cell. It's important to note that when kids get sick, they tend to excrete excess levels of a particular hormone called arginine vasopressin, or AVP, otherwise known as antidiuretic hormone. This promotes the retention of water at the level of the kidneys, leading to hyponatremia. Antidiuretic hormone is released secondary to many of the reasons children are admitted to the hospital. This includes pain, nausea, stress, a postoperative state, hypovolemia, certain medications such as anti-seizure medications, opiates, and SSRIs, pulmonary disorders such as pneumonia or pneumothoraces, and central nervous system disorders such as meningitis. Excess antidiuretic hormone, coupled with the previously common practice of prescribing hypotonic fluids such as quarter or half NS to children when admitted to the hospital, can often lead to hyponatremia, which has been found to complicate about 30% of pediatric hospitalizations. The bottom line is don't give hypotonic fluids to sick kids on the ward because you can induce hyponatremia. This is a common error that you don't want to make. Be sure to include potassium in maintenance IV fluids as long as there's no contraindication to giving potassium. Adding 20 milliequivalents per liter of potassium chloride, abbreviated KCl, is appropriate for most patients. Consider contraindications to potassium supplementation, such as impaired ability to clear potassium or elevated potassium levels that may be associated with renal insufficiency or failure, systemic acidosis, use of potassium-sparing diuretics, adrenal insufficiency, or in the presence of severe tissue damage such as burns. Now, based on a growing body of evidence, the American Academy of Pediatrics recommends isotonic fluids such as D5W normal saline for maintenance IV fluid therapy between the ages of 28 days and 18 years with some exceptions. Some of these exceptions include renal dysfunction, severe burns, or neonates who are younger than 28 days old or in the NICU. The fluid choices for these patients may vary, such as if a patient has renal dysfunction, you might choose to give him a lower osmolality load with half normal saline. Additionally, a neonate admitted to the neonatal ICU will require D10W quarter normal saline because their dextrose requirements are higher and their sodium requirements are lower than the typical child admitted to the ward. Despite this, some institutions may still provide hypotonic saline, such as half normal saline, due to concern of hypernatremia or hyperchloremic acidosis, so be sure to check with your seniors what the preference is in your institution. The most widely adopted method for estimating maintenance fluid volume is the Holliday-Sager method, which determines the rate of fluid needed based on the patient's weight in kilograms for a child. This is known as the 4-2-1 rule. For the first 10 kilograms, multiply each kilogram by 4 mLs. For the second 10 kilograms, multiply each kilogram by 2 mLs, and for each additional kilogram, multiply by 1 mL. We add these values together, and this gives us the total mLs per hour of maintenance IV fluids. So let's run through an example. Here we have a 6-year-old child who weighs 25 kilograms. For the first 10 kilos, we multiply this by 4, which equals 40 mLs per hour. For the next 10 kilograms, we multiply this by 2, which equals 20 mLs per hour. And for the remaining 5 kilograms, we multiply this by 1, which gives 5 mLs an hour. We add these three values and get 65 mLs per hour, so this would be the prescribed rate of fluid for this patient. If you suspect a patient may be dehydrated or have hypovolemia, you can calculate the volume of fluid deficit using their pre-illness weight if known and subtracting their illness weight. Children who receive appropriate well-child checks at regular intervals will often have a reliable pre-illness weight on file to use to determine the fluid deficit when ill. However, if the pre-illness weight is not known, clinical observation of physical exam findings may be used to approximate the percentage of dehydration, which can be seen here in this table. You will gather information based on various clinical observations, such as appearance of the patient's eyes, presence or absence of tears, the appearance of the lips, quality of the pulse and capillary refill, and whether the urine output is normal or diminished. If the patient is greater than 1 year of age or considered a child, you would estimate 3, 6, or 9% dehydration based on if their clinical appearance meets mild, moderate, or severe dehydration. If they are an infant less than 1 year of age with greater total body weight at baseline, you would estimate 6, 10, or 15% dehydration if you suspect mild, moderate, or severe dehydration based on the infant's clinical appearance. After estimating the percentage of dehydration, determine if the dehydration is isotonic, hypotonic, or hypertonic based on the sodium levels. If the sodium level is normal, this is isotonic dehydration, which is the most common form of dehydration in children. For sodium levels less than 135, this is hypotonic dehydration, and for sodium levels greater than 145, this is hypertonic dehydration. Based on these sodium levels, the replacement fluid and monitoring may be different, and I'll give you some examples in the next several slides. Remember, in children who are found to have mild to moderate dehydration and are able to drink by mouth, it is always preferred, if feasible, to provide an oral hydration solution, such as Pedialyte. Consider giving Zofran 30 minutes prior to starting the oral rehydration solution, and then plan to give 50 ml per kilo over 4 hours for mild dehydration or 100 ml per kilo over 4 hours for moderate dehydration. If the patient is able to tolerate oral rehydration and ongoing losses are not severe, you may discharge the patient home. Parents should continue to reassess their child's fluid status every 2 hours and return to the emergency department if unable to maintain fluids orally. Patients who are still breastfeeding should continue to breastfeed, and children may eat a regular diet as tolerated. The BRAT diet, which stands for bananas, rice, applesauce, and toast, is no longer recommended as it is too limiting. For severe signs of dehydration, you'll need to admit these patients to the hospital. You can calculate the fluid deficit by knowing that for each percentage of dehydration that you are estimating using this table equals 10 ml per kilo of fluid deficit. And again, be sure to use the patient's pre-illness weight if available, otherwise you may underestimate the fluid deficit. In the acute phase, give 20 ml per kilo of normal saline over 10 to 15 minutes. Repeat until circulation is stable up to 3 boluses. Be very mindful if you think this child may have a heart condition, as fluid boluses may push this child into heart failure. Prior to any bolus, listen to the lungs for crackles, feel for an enlarged liver, and look at the ankles to look for evidence of edema secondary to cardiac dysfunction or heart failure. Also be sure to check a glucose if dehydrated. If the glucose is less than 40, give 2 to 4 ml per kilo of D10W IV glucose over 15 minutes. After estimating the percentage of dehydration, determine if the dehydration is isotonic, hypotonic, or hypertonic based on the sodium levels previously described. So let's work through an example. Here we have a 10-month-old, 12-kilogram infant with uncontrolled vomiting for 24 hours and signs of dehydration as manifested by dry lips, slightly decreased capillary refill of 2 to 3 seconds, and decreased urine output. Based on her physical exam, you determine that this infant has moderate dehydration, which equates to 10% dehydration. Her serum sodium level is 140, meaning that she has isotonic dehydration. She is given 1 20 ml per kilo normal saline bolus in the emergency department, which is 240 ml based on a 12-kilogram infant. For the fluid deficit, remember that for each 1% dehydration, this equals 10 ml per kilogram of fluid. Therefore, we take the 10% dehydration seen in this patient, multiply by 10 ml, and then by the kilograms. This gives us a 1200 ml estimated fluid deficit. Given that this is isotonic dehydration with a sodium level of 140, replacement fluid should be given as normal saline, but be sure to add D5W for the dextrose component. You'll want to hold on adding potassium until the urine output is well established. We subtract the IV fluids given in the acute phase of volume resuscitation in the emergency department, which was 240 ml, and this leaves us with a remaining 960 ml of fluid deficit. For isotonic fluid resuscitation, this fluid deficit should be replaced over 24 hours minus what was given during the acute phase of volume resuscitation. Half of the remaining fluid deficit should be replaced over 8 hours, and the second half of the fluid deficit should be replaced over the next 16 hours on top of maintenance IV fluid needs. Therefore, we would give the first half of the volume, or 480 ml, over the first 8 hours for a rate of 60 ml per hour, and the remaining 480 ml given over the next 16 hours at a rate of 30 ml per hour. Remember, this is on top of maintenance IV fluid requirements. Now let's imagine another example. Here we have a 24-month-old, 16-kilogram child with uncontrolled vomiting for 2 days, with sunken eyes, no tears, and no wet diapers for 24 hours. Based on her physical exam, you determine that she is severely dehydrated, which equates to 9% dehydration because she's a child and not an infant. Her sodium level is 150, consistent with the diagnosis of hypertonic dehydration. In the emergency department, she is given 2 normal saline boluses of 20 mL per kilo. This equals 640 mL. We calculate the fluid deficit by multiplying the percent dehydrated by 10 mL by the weight, which equals 1,440 mL. Even though this is hypernatremic dehydration with a sodium level of 150, you should still begin fluid replacement with D5 normal saline. If sodium levels are markedly elevated, such as greater than 160, consider starting with D5 half normal saline. You will want to monitor sodium levels every 2 to 4 hours, and if sodium levels are unchanged, then you can change fluids to half normal saline with close monitoring. We subtract the IV fluids given in the acute phase of volume resuscitation in the emergency department, which was 640 mL, leaving a remaining fluid deficit of 800 mL. For hypernatremic fluid resuscitation, this fluid deficit should be replaced more slowly over 48 hours with a change in serum sodium by no more than 10 milliequivalents per 24 hours. This is to minimize the risk of cerebral edema that can occur if the sodium drops too quickly. You would first subtract what was given during the acute phase of volume resuscitation in the emergency department, then give half of this deficit over the first 16 hours, and the second half over the remaining 32 hours on top of maintenance IV fluids. So therefore, you would give the first half, or 400 mL, in 16 hours, which would equate to 25 mL per hour, and then give the second half, or 400 mL, in the next 32 hours at a rate of 12.5 mL per hour. Again, this is on top of maintenance IV fluid needs. Now let's do another example. Here we have a 3-year-old 20-kilogram child with uncontrolled diarrhea for 2 days, only drinking water, with dry cracked lips, delayed cap refill, and no wet diapers for 24 hours. Based on his physical exam, you determine that he is severely dehydrated at approximately a 9% dehydration based on the signs of severe dehydration in a child. The serum sodium levels are 120, categorizing this patient as having hypotonic dehydration. In the emergency department, he is given just 1 normal saline bolus of 20 mL per kilo, which is 400 mL. We calculate the fluid deficit by multiplying the percent dehydrated by 10 mL by the weight, which equals 1,800 mL. In hyponatremic dehydration with a sodium level of 120, you should begin fluid replacement with D5 normal saline. However, if sodium levels are less than 120, or if there are signs of CNS symptoms or altered mental status, consider giving 3% or hypertonic saline. This is also known as rock salt. Give hypertonic saline over 3 to 4 hours and monitor sodium levels every 2 to 4 hours. Again, we subtract the IV fluids given in the acute phase of volume resuscitation, which was 400 mL, leaving a remaining 1,400 mL of fluid deficit. For hyponatremic fluid resuscitation, this fluid deficit should be replaced more slowly over 48 hours with a change in serum sodium by no more than 10 milliequivalents per 24 hours. In hyponatremic dehydration, this is to minimize the risk of osmotic demyelination syndrome that can occur with a rapid change in serum sodium. This is the opposite of cerebral edema that you see in rapid sodium changes with hypernatremic dehydration. After you first subtract what was given during the acute phase of volume resuscitation in the ED, you will give half of this deficit over 16 hours, with the second half over 32 hours on top of maintenance IV fluids. Therefore, you'll give the first half, or 700 mL, in 16 hours at a rate of 43.8 mL per hour, and then give the second half, or 700 mL, in the next 32 hours at a rate of 21.9 mL per hour. Again, remember that this is on top of maintenance IV fluid needs. Now to calculate maintenance IV fluids using another technique. For this 12-kilogram infant, remember we use the 4-2-1 rule, which will determine the rate of fluids in mLs per hour. For the first 10 kilograms, we multiply 4 mLs for each kilogram, which equals 40 mLs per hour. For the second 10 kilograms, we multiply 2 mLs for each kilogram. So for this 12-kilogram infant, we would multiply the remaining 2 kilograms times 2, equaling 4 mLs per hour. Therefore, the total maintenance IV fluids would equal 44 mLs per hour when added together. So for this patient who has limited oral intake since she is so sick, you would write for D5, which stands for 5% dextrose in water, plus normal saline, given that she has an increased risk of elevated antidiuretic hormone release due to the uncontrolled nausea and vomiting. And again, if her urine output has been established, remember to add potassium at 10 to 20 milliequivalents per liter. So let's put it all together. In this 12 kilogram infant with 10% moderate dehydration, we've already calculated the maintenance fluid requirements to be 44 mLs per hour. In calculating the fluid deficit, we take 10%, multiply by 10 mLs, and then by the kilograms, equaling 1200 mLs. We subtract the normal saline given in the emergency department for fluid resuscitation, which was 1 20 ml per kilo normal saline bolus, so we subtract 240 mLs, equaling 960 mLs of fluid deficit remaining. We give half this volume, or 480 mLs in the first 8 hours, equaling 60 mLs per hour. This equates to 60 mLs per hour of fluid deficit and 44 mLs per hour of maintenance IV fluids for a total rate of 104 mLs per hour for the first 8 hours. Then we give the second half, or 480 mLs, in the next 16 hours, which is a rate of 30 mLs per hour. This equates to 30 mLs per hour of fluid deficit and 44 mLs per hour of maintenance IV fluids for a total rate of 74 mLs per hour for the remaining 16 hours. So in summary, fluid management can be one of the most challenging parts of pediatric care. The details matter, and be sure to check your math twice. Ensure the accurate dosing of electrolytes and rate based on the patient's deficits and maintenance IV fluid needs. And always have someone check your work while you're learning. Thank you, and this concludes our module on pediatric fluid management.